All right. Hi, everyone. Welcome, welcome. I want to welcome you to I think it's our sixth seminar or webinar in the Treatable, Not Terminal series. And our topic today is assisted suicide in eating disorders, and really assisted suicide and euthanasia in eating disorders, ethical challenges and considerations. My name is Chelsea. I'm the director of Eat, Breathe, Thrive, which is a nonprofit organization that's working to prevent and help people to recover from eating disorders. And today we are diving into one of the most really challenging and controversial topics in modern medicine generally, least of all eating disorders. And that topic is assisted suicide and euthanasia, which is sometimes referred to, terms vary in different countries, sometimes broadly referred to as physician-assisted death. And particularly what we want to talk about today is how this practice relates to psychiatric conditions. And we're honing in on eating disorders, but I think you'll find in this conversation that it broadly relates to really any psychiatric condition and even conditions beyond psychiatry. Many of you will know that my colleague, Dr. Catherine Cook-Catone, and I recently conducted a systematic review on assisted death in eating disorders. And what we found was really alarming. It was that people with eating disorders have died by assisted suicide and euthanasia in multiple countries around the world, including the United States. And that's important because in the United States, the law strictly limits this practice to people with terminal conditions. So I am really excited for this conversation because we're bringing together four physicians from really different specialties, which I don't think is fairly rare in these kinds of webinars, to explore some of the ethical, legal, and clinical challenges surrounding this topic. I want to say right at the outset, and then we'll get into housekeeping introductions, that this isn't just a theoretical or a philosophical conversation. And I think sometimes it can feel that way. But having done this research and read these case studies, I want to remind you that these are real human beings and real families that we're talking about. This is a highly consequential topic. So even though it's complex and even though it can be polarizing, it's really urgent right now. So on that note, very quick housekeeping. The session is being recorded, and that's so that people who are not here right now can benefit from it. We're going to include Q&A at the end, so I want to invite you as we get to that time to submit your questions in the chat. And if you do drop a question in before, I'm really lucky to have Melanie here to help me grab those questions and remind me when we get to Q&A. And then last but not least, if you do need closed captions, they are at the bottom of your screen in the toolbar. If you click on captions and turn closed captioning on, you have that option available. And so on that note, I'm really honored to introduce you to today's panelists, starting with Dr. Angela Guarda. Dr. Guarda is a leading psychiatrist specializing in treating eating disorders. Dr. Guarda brings a wealth of clinical experience and insight into the treatment of patients with eating disorders. And, this language is convoluted and really hypercharged, but we'll just say particularly people who have had their illness for a really long time and maybe dealing with very severe medical complications as a result of their illness. We're also joined by Dr. Annette Hansen. Dr. Hansen is a forensic psychiatrist, and I'm really excited to have her here today because she has extensive experience in mental capacity assessments, which is a topic that is often poorly understood in assisted suicide and euthanasia. She's written about the impact of assisted suicide and euthanasia on people in state institutions. This is something that I think is really underthought about, and the complex ethical and legal dimensions of this issue. I'm also delighted to be here with Dr. Mark Conrad. Dr. Conrad is a psychiatrist and an ethicist known for his work on the concept of medical futility. I will say I leaned very heavily into his writing, as well as that of Dr. Hansen and Dr. Guarda, really all of these, but on futility, because again, poorly understood issue, and it's a term that gets used a lot without real concern for what it means. So he's written extensively about futility, as well as the ethical issues with euthanasia and assisted suicide, and importantly, the moral responsibilities of healthcare providers as it relates to this issue. And finally, here with me in the UK, not literally here with me in this room, but we have Dr. Claude Regnaud, a palliative care physician. And palliative care, as we know, is very, very relevant to this issue. He has deep understanding of end-of-life issues and has advocated strongly for the importance of keeping assisted dying out of healthcare. Okay, so on that note, we have a lot to cover, and I'm going to dive straight into our questions. And our first question, I'm going to direct this to you to begin, Dr. Guarda, and then we can go one by one. And I love that I had it in front of me and then I just X'd it out. That's beautiful. That's just how these things go. One moment. Okay, there it is. Okay, here it is. Our systematic review revealed that over 60 people with eating disorders have died through physician-assisted suicide and euthanasia. And I really want to specify there that the reason they were granted euthanasia or assisted suicide was because of an eating disorder. So we're not just talking about people that happen to have one. To begin, what are your thoughts on these findings, and how has your professional experience shaped your views on this topic?
Well, I think your findings are important and very alarming because they are no doubt an underestimate of the actual number of individuals who have died through some kind of physician-assisted death intervention. And they are also alarming because we know that anorexia nervosa is a puzzling illness. We don't understand it. We don't really know the best treatment or the cause. And we know that individuals with this disorder develop life-threatening malnutrition. They certainly can die from this illness, but we cannot predict who is going to die. And this is not an incurable condition in the sense that we have a medicine for it. The medicine is food. What is difficult is to help patients accept the treatment they need. And we know that weight restoration is the best predictor of recovery from anorexia. So if you can't restore weight, you are not likely to get well. However, it's not sufficient, so that there is a high relapse rate. So I think those kind of summarize some of the problems. I think the terminology that we use in anorexia is very important because patients over-identify with the illness. They often, especially when it becomes chronic, feel like they don't want to give it up in some way. It doesn't make sense. It's confusing to someone who doesn't have the condition. Patients actually can recognize that other patients should get well, but they have trouble applying the same logic to themselves. So those are kind of some of the problems that I see.
Thank you. You covered a lot of bases there, and I think you also gave a nod to terminal anorexia, which is sometimes floated around in these conversations. I want to go to you, Dr. Hansen. Do you want to speak a little bit about just your initial thoughts, and then also the professional experiences that inform your understanding of this issue?
Yeah, absolutely. Thank you for the opportunity to be here today. So, as a forensic psychiatrist, I have done and I train doctors to do capacity assessments in a variety of settings, both civil and criminal. And for those who don't routinely do this work, the important thing to remember is that there's a difference between capacity versus competence. So, capacity is something that someone evaluates and forms an opinion about, but competence is a legal term. It's what courts adjudicate. Okay. Then when you do the assessments, you have to think about what the legal standard or test is. And the thing that really strikes me is how low the bar is under these laws to be competent or have capacity for assisted suicide. Essentially, you have to know three things. You have to know that you have a serious, potentially terminal illness, that you have maybe 6 months to live, and that if you swallow the medication, you'll die. Now, think about how impaired you'd have to be to fail that test. That is a serious problem. When it comes to doing the assessments, assessments are a very comprehensive evaluation. You do an evaluation of the patient, you interview collateral historians, you review medical records. And the thing that is really striking is that the patient controls this process, okay? So if a patient is being coerced, they can refuse permission to talk to someone who has knowledge of the coercion. That's a serious fault. Now, MAID providers will say you don't need a mental health professional to do these assessments because, we assess capacity all the time for things like surgery or other medical procedures. What people don't acknowledge is that the law requires this to be a different process because it requires an assessment not just of capacity, but also coercion. Okay, the decision must be non-coerced. There is no standard of practice for assessing coercion, and I can tell you from listening to talks by MAID providers, they're not doing this. Okay. A big fault in this law is that there is no mandatory reporting duty for any physician to do something about a patient who's being coerced. Some states have elder abuse laws, but that pertains to financial abuse, not abuse under these kind of laws. And that's a serious flaw.
Wow, you packed so much into that, and I am so for anyone who was like trying to take notes, we're going to come back to capacity because we could you gave so much there, but I think it's a really important and misunderstood part of this issue. So thank you, Dr. Hansen. I'm going to go to you, Dr. Conrad, next. Your initial thoughts, and then also how you come to this professionally.
Thank you so much, Chelsea, and I really appreciate being invited today and your interest in the work that I've done. I'm a practicing psychiatrist as well as a medical ethicist, and frankly, in the last several years, my career as a medical ethicist has become almost exclusively focused on this issue, trying to make a very deep and well-considered case for why this is really neither good medical ethics nor good public policy, and why these kinds of procedures, euthanasia and assisted suicide, really are not medical treatment in the conventional sense of the word. But I also want to appreciate very much the study that you and Dr. Cook-Catone did on eating disorders. It really is the most thorough and focused study to get data on the use of assisted suicide and euthanasia specifically for those with eating disorders. And in addition, you furnished a very comprehensive overview of the worldwide laws and how they're changing to date, which is something I particularly appreciate and use a lot of your work and some of my efforts and talks. So, it's a really important contribution to the conversation and to all the typically elusive details when it comes to data in these kinds of activities. You've been able to show that there are eating disorders patients in Belgium and Netherlands, even in the United States, and a couple of other places that have been granted access to these kinds of procedures. But I also want to just specifically say that eating disorders are a very specialized area of psychiatry. I'm a general psychiatrist, and I think this is one of the truly deep subspecialties in mental health. So, by the way, I am not an eating disorders specialist. So when I get a patient come to me with an eating disorders, I refer them to a specialty program with specialists. But it's often very hard to get them in. There are long waiting lists in the United States. It can be a month. In Canada, for example, it can be over a year. So many people commonly lack access to high quality multidisciplinary treatment. So I think that this is, particularly when it comes to eating disorders and psychiatric patients and their eligibility for euthanasia and assisted suicide, I think these are some of the most problematic kind of cases. Moreover, the delusional level of cognitive distortions regarding food and body image in eating disorders, that becomes the irrational lens through which they try to make a decision to refuse treatment or to seek assisted dying. So a clinician who assumes that a patient has the capacity to consent to assisted suicide rather than further treatment is not relieving the patient's suffering, but is actually furthering and colluding with the disease itself. And that's especially true when individuals are highly ambivalent about recovery, which frankly, most of them in my experience are.
Yeah, I'm so glad you said that, Dr. Conrad. And I want to say that's also, if you really let that land with you, that's an incredibly heartbreaking reality that, a person is coming and is particularly ill and maybe also suicidal and, perhaps out of a mistake, but, if being the most generous read of that situation, a physician responds to that with, a prescription for lethal medications, and that's the end of that person's life. That is just heartbreaking. So I'm really glad you stated it, and just want to draw an underline around, that's a human being. Dr. Wegner, we'll go to you last but not least, and then we'll get into some of our other questions.
Well, thank you. Such wonderfully erudite answers. In complete contrast, I'm going to explain that I follow the hypothesis that humanity has an innate ability to screw things up. And in addition, it has a disturbing habit of hiding its mistakes. And that combination is particularly apparent in physician-assisted suicide and physician-assisted euthanasia. And what your paper has done is basically to underscore that. I told you it'd be a contrast.
And short and simple. Short and simple. Thank you. Yeah, I'm glad you noted that, and I'm grateful for your kind words and also for yours, Dr. Conrads. The under reporting and the lack of transparency that we found is pretty alarming. All right, well, let's go to our first question. I'm going to go back to you, Dr. Guarda, for this one, and this is something that's been discussed a lot, and I'm going to rephrase it slightly from how I'd given it to you. We saw in 2022 the publication of an article proposing, it summarized the cases of 3 now deceased patients, 2 of whom were prescribed lethal medications, 1 of whom was not. And it proposed a new clinical category, not quite a diagnosis, but a clinical category of eating disorders, which is called terminal anorexia. And there's been a huge response, huge. Some people would like it to be larger. I heard in our last panel that it would have much preferred it to be a much larger response, but it's been a really resounding rebuttal and rejection of this idea. I've always, at this point, I look back on that and I agree with the rebuttal and the paper you wrote, which was excellent, but I almost wondered if it was a red herring in some ways. We were really focused on the language of terminal anorexia and not so focused on the fact that it was being used to grant patients access to lethal drugs. So I wondered if you could comment a bit on your thoughts on either that term, because one thing that struck me is while there was at one of our big professional conferences this year, one of the authors came out and said, okay, I'm not going to use this term anymore. I hear it. There was still I won't use this term anymore, but also anorexia is people, it can be a terminal condition, and thus it can be eligible for assisted suicide, was what I heard. So what are your thoughts on the conceptualization of eating disorders as some people, a small minority is what others would say, being framed as a terminal condition and granted access to these medications?
Well, I think, again, it's important to clarify that anorexia is, after opioid abuse, the most lethal psychiatric condition that we have. So no one is contesting that you cannot die from anorexia, and that's important to understand. However, it is not a terminal illness in the sense of us not having a cure for it. We just can't get the patient always to accept the cure. But I think that the only reason why we should need to define this category of who actually is stage 4, as it was described in the lecture that you're alluding to, or who has terminal anorexia, the only reason for that description is to legitimize the use of physician-assisted death for anorexia nervosa. And that's the problem here. We don't need the diagnosis. It is true that some patients will die from the disorder, but the article that you're referring to described 4 supposed criteria that would help identify individuals who are likely to succumb from the illness or who may be eligible for physician-assisted death. And I think it's important to just reiterate what those 4 criteria were. The first was the diagnosis of anorexia. Okay, problem with that is that most people with anorexia will not die from the illness. The second criterion was age over 30. And we know that recovery from anorexia nervosa is a protracted process. It often takes years, sometimes decades. I have seen patients age 70 recover, not a lot, but some. And I have seen patients who spent months in the ICU, extremely ill with anorexia, recover and go on and become professionals, have families. It's a minority, but it's a significant minority, and we don't know who they are. We have no way of figuring out who's going to recover and who won't. Sometimes the simplest cases become chronic, and the most chronic cases recover. And we know that from longitudinal studies that recovery is gradual, and that even at 10 years compared to 20 years, we see double the number of individuals recover with a majority of chronic patients recovering in 22 years. So that's problem with the second criteria. The third criterion was that, I'm sorry, the third criterion, tell me what the third criterion is.
The patient, it may be the patient understands
has failed. The patient has failed multidisciplinary expert care. So Mark referred to the problem with accessing care, which I can talk about later. But besides the problem with accessing care, we don't even have a definition of what expert multidisciplinary care is. The field doesn't agree on it. Programs do different things, and patients respond to different programs and to different approaches. So there's no way to define what that failure is accurately. And then the fourth criterion is that a patient has capacity and can make a reasoned, consistent choice to choose to end their life if they meet these other criteria. And the problem there, which has already been alluded to, is that capacity in anorexia is lack of capacity in anorexia is subtle. It's not easy to discern. Patients are not frankly delusional in the sense of thinking that the CIA has implanted something in their head that is controlling them. They appear to have impaired capacity specifically in the area of accepting the treatment that they need. They are scared and anxious about treatment that is going to result in weight restoration, which, remember, is the best predictor of recovery. So if we don't achieve that, we don't achieve anything. So that, to circle back to your question, my concern with the terminology is that it can become a self-fulfilling prophecy, because obviously once you've been diagnosed by some experts supposedly as being terminal, how do you become unterminal? Especially when you identify with the disorder as the patient. So I'll stop there. Thank you.
Yeah, that was excellent. And I can say, as somebody that works with people with eating disorders in the community, that we're seeing that identification with that illness happen, those fears be expressed of, well, maybe I'm one of those terminal patients, maybe I'm one of those people that will never get better. Um, I'm going to use your answer as a segue. I'll also just briefly mention, just to give credence to that paper, because we don't have it in front of us, but there's a criterion around the patient has to be over the age of 30 as well. And I'll just say in our study, it was an international study, but we found a third of the patients that had been euthanized or assisted in suicide were between the ages of 18 and 30. They were under the age of 30. So, I mean, and another third was between the age of 30 and 40. So we're talking 2/3 of them were under the age of 40. So that's I mean, there's problems with that criteria to begin with, but also it's certainly not being, I've also met patients that were under the age of 30 when they were offered MAID for anorexia. So, but one of the criteria that you referred to there, it's a good segue to a question I want to go to you with, Dr. Comrade, and I have the gift of having it right in front of me, so I'll just read it here. But it was a consistent, clear expression by an individual who possesses decision-making capacity, as Dr. Guarda just said, that they understand further treatment to be futile and choose to stop trying to prolong their lives and accept that death will be the natural outcome. I remember reading that and having read some of your research going, I don't know if they know what futile means in this situation, because futility in medicine is a very specific term. So I wondered, Dr. Comrade, if you could shed light on the term of what medical futility is, and also in a psychiatric context, talk about some of the controversy of applying medical futility, or the idea that that treatment is futile, to psychiatric conditions.
Yes, indeed. Futility is really a statement of prognosis that with or without treatment. And of course, that's part of the controversy. Does futility mean futile with treatment or futile without treatment? And that's actually not spelled out. And indeed, in many jurisdictions, they allow patients, which is the state of the art of medical ethics, to refuse treatment. Thus, by virtue of their refusal of potentially successful or effective treatments, they create for themselves futility. And as a matter of fact, for example, in Canada, there is no requirement to try all potentially effective treatments. So you can actually produce futility. But the thing is, in psychiatry in particular, the notion of prognosis in general is very underdeveloped. We really have a hard time predicting the future, and especially in any one individual, right? So we can say something about 100 people and what their potential prognosis is. But in terms of predicting in any one particular individual, it's very elusive. As a matter of fact, we have a hard time predicting suicide, which is something we have to, suicidal behavior, which is something we have to decide in psychiatric emergency rooms every day. So the prognostic predictors for eating disorders in particular are very elusive. Futility is kind of a straw man, a construct, a shibboleth that's become a term of art for proponents and policymakers and legislators as the key justification for assisted suicide and euthanasia. It's really the politically, not medically, accepted ethical entree into justification for these procedures. And remember that evaluating people for physician-assisted dying is a legal activity to see if they meet legal statutory criteria, not a medical activity. Medicine did not develop the criteria. Medicine didn't even ask for the legalization of these procedures. Legislatures and courts have. So it's supposed to mean medical futility when you talk about futility, but that is so loaded with all sorts of contributors to that futility. Things like inaccessibility of treatment or expertise, inadequate funds, lack of accurate diagnoses of the comorbidities that often come with eating disorders, ableism, inadequate resources for things like housing and food and employment. All of those go into the reckoning about what's going to happen with or without treatment. Then there's also, in terms of so-called futility, another factor is the psychological exhaustion of families, even treaters themselves, that produces a kind of resonant chamber of hopelessness. For those who are familiar with psychological terms like projective identification and transference and countertransference, will be familiar with some of these dynamics. And for eating disorders, as Dr. Guarda pointed out, there is not great agreement on what constitutes standard treatment protocols, because most treatment takes place in specialty clinics, as I said before, where I refer my patients to people like Angela and their inpatient programs, which are very different than the general psychiatric hospitals and psychiatric clinic. So in many of these programs, they all have their own recipe and approach. So standardized treatment protocols nationwide are particularly underdeveloped. The goals may be fairly consistent from program to program, but the methods to achieve those goals are not. So if you're using many different kinds of protocols and many different kinds of treatments, it's really very difficult to reckon in one particular context what the prognosis is going to be of that patient. What would it be in a different treatment center? So these are some of the very, very complicated things that go into this this term that has been so used politically and legislatively, but not so much psychiatrically, futility.
Yeah, thank you. Thank you, Dr. Comrade. One thing that struck me as we were writing the article and reviewing this particular paper was that the assessment of futility was placed in the hands of the psychiatrically ill patient. The criteria, the way it was worded, said the patient understands further treatment to be futile. And having had a very severe eating disorder, I would tell you what, in the throes of my eating disorder, that is exactly how I felt about any treatment. Of course it's futile. It's never worked before. So it was that the vulnerability of the patient in that moment, I think. And I think that what you spoke to around family burnout and psychological exhaustion, all of that. There's a lot there that informs the kind of conclusion that's being arrived at, that further treatment is futile. And on that note, I want to turn to you, Dr. Hansen. That there's been a lot of conversation around physician-assisted suicide or euthanasia being an autonomy supportive treatment, which I mean, even that word, calling it a treatment, is problematic. And that really, to get to autonomy, you have to start with the patient has mental capacity. And I've seen it get thrown around in articles and in scholarly papers, even in custodianship hearings, and it's often, expressed very ardently. This patient has mental capacity. But how the assessor arrived at that conclusion is often not explicated. So I'd like to ask you, one thing that's, as Dr. Comrade spoke to, we looked at every jurisdiction in which physician-assisted death is legal, and in every one, there is something in the law that says the patient has to have mental capacity to make this life-ending decision. So I want to ask, can you discuss some of the kind of common misconceptions about mental capacity? I think you said some in the introduction, and also the difficulties of assessing it in psychiatric patients, but also can you just explain how are these assessments being made? Is it a rigorous, standardized process? Is it up to clinician judgment?
Yeah, that's a great question. And I've listened to talks given by MAID assessors, and what I've heard is horrifying. I heard one assessor say that they could assess capacity in a nonverbal patient just by answering yes or no questions with the raising or the lowering of a thumb. That horrified me. I reviewed training materials that they were providing to teach people how to do capacity assessments. Out of all of that material, there was one question related to psychiatric conditions and psychiatric treatment. It's horrifying. It's a very detailed, complex process. in addition to talking to the patient, you have to review medical records. You have to talk to collateral historians. You have to consider their vulnerabilities. And this is where everything kind of falls off a cliff. So if a patient is lacking certain abilities, how are they compensating for that? Who is doing that for them? Who do they depend on? And there's no current practice to allow for that. There have been cases where an individual was brought to a psychiatrist for capacity assessment in the United States. The psychiatrist was concerned that the elderly woman was being coerced by the daughter who accompanied her to the assessment. And so he said that she lacked capacity. So then the daughter just took her to a psychologist who said she's fine. Okay. So, doctor shopping is a problem. Okay. There is no ability to challenge a faulty capacity assessment. Now, ironically, if this person were a criminal defendant, that would be all covered under the law. So if one side or the other has concerns about a faulty assessment, if the assessor is missing certain information, you can go to court and have a hearing. Even for guardianship, there's a hearing. There's a way to bring all the information out. All of that is lacking under these laws.
Go ahead, Dr. Conrad. Yes, please. You are on mute, though.
Sorry about that. The American Association of Forensic Psychiatry has a template for capacity assessment. And that template is about 8 to 10 pages long with a variety of questions and dimensions for assessment. And as a result, I consider capacity assessment another specialty in psychiatry. It's a subspecialty that is particularly in a skill set of people like Dr. Hansen with forensic psychiatrists and also the so-called consultation liaison psychiatrists who work in general hospitals, going onto surgical wards, medical wards, when they're called in to assess patients' capacity to refuse treatment or participate in procedures. So even I, as a psychiatrist, I do not consider myself qualified to do a proper capacity assessment, to do that 8 to 10 page template that my profession has set up. Well, in California, all you have to do is to fill out, or at least the template is to ask 4 questions. Same thing in Ontario, Canada. They have their guidelines, 4 very simple questions. So it's a completely different species of capacity assessment that is being done in these settings for assisted suicide and euthanasia than is typically done. And indeed, the whole science, if you will, of capacity assessment, the clinical science, is really based on a whole entirely different domain of procedures. Capacity to refuse treatment, to accept treatment, legal capacity to stand trial and participate in your own defense and so forth. Totally different than what we're talking about here, where these kind of criteria are not developed at all.
Yeah, thank you, Dr. Conrad. I want to, again, just throw an underline around what you just stated there, that I think one of the common misconceptions is that if a person has capacity to stand trial, they have capacity to end their life. But actually, our understanding and all pretty much conceptualizations of capacity recognize that it's a decision-specific assessment. So how we understand capacity to stand trial or capacity to refuse treatment is very different than how we understand capacity. And those require different assessments, different standards. And there are no standardized assessments for for assisted death. I do want to go back to you, Dr. Guardo, on this, but I'm going to turn, because I kind of want to, can you briefly weigh in on the complexity of assessing capacity and eating disorders specifically, because I think that's also under talked about. And then I'm going to come to you, Dr. Ragnar, with our next question.
Well, I think, what it boils down to is that individuals with anorexia are scared of the treatment they need. And that makes it difficult, but in other ways, they appear to be rational. And it's just very, that is something that most physicians in different specialties, including psychiatrists who don't work with this population, may not understand. So that I think there's a problem with the fact that capacity, we're trying to decide on whether a patient has capacity to accept a certain treatment, including an intervention like MAID, when they can't reason through why they can't accept the treatment that will actually help them get better. So I think that's kind of a crux of the problem here, and why it is it doesn't make sense that they should be able to choose death but not be able to choose cure. Their choice is impaired by their illness. Their choice to accept treatment is impaired. So how can their choice to accept physician-assisted suicide be rational?
Yeah. I've gone back and forth with my co-author Catherine on this, and I kept wanting to write in our paper, capacity impairments and capacity eating disorders can be subtle, and she kept saying it's not that they're subtle; it's they're not subtle at all.
But very circumscribed, right?
Yeah, but they're disguised by remarkable lucidity, remarkably articulate individuals. And having many people with lived experience of eating disorders in my life, when we have conversations and I say, do you think you had that capacity at that time? Almost across the board, we look back and go, absolutely not. But we could have talked circles around our physicians, saying, oh yeah, I know what I'm doing. I understand, the consequences of my illness. I understand, the impact of starvation on the brain. This is an informed decision.
Right. So there's no question they can weigh the pros and cons. They can tell you the risks and benefits, but they can't appreciate how the risks apply to themselves often. Yeah. So for instance, if you say, well, your potassium's really low, it's life-threatening, you can develop an arrhythmia any minute. The response is, yeah, but I've run low potassiums many times. It's never happened to me. It might happen to her, but not to me. And the other issue is the kind of ambivalence that you see about recovery and about treatment that is part and parcel of anorexia, in the sense that patients want help, but they want relief from their suffering without gaining weight. And that's what, as a practitioner, won't work. So, a lot of the challenge in treating anorexia is actually developing enough of a therapeutic rapport with the patient to support them and help them to do what they're scared to do, to gain weight and eat more normally. This kind of brings me to the issue of kind of therapeutic alliance, which I think is important because we often do see patients recover in non-specific care. And the question with a therapist who maybe has no expertise in anorexia, and it kind of reminds me of a patient I saw very early on in my career. She was a teenager, and we admitted her 3 times at a life-threatening weight. We weight restored her to a normal weight. We discharged her back home, and she immediately relapsed again. And the 3rd time her parents brought her in, I said to them, I'm sorry, I've tried everything I know. I think you should try another program because it's not working here. I didn't say she's untreatable. I said, try somewhere else because maybe she'll connect better at another treatment center. Well, I didn't hear from her for 10 years. And she called me up and I said, I was actually surprised she was alive. And she said, can I come see you? I have a surprise for you. And I opened the door and I saw a 25-year-old, 9-month pregnant, totally normal weight woman. Wow. And I said to her, how did you do it? Because I really didn't think you were going to survive. And she said, I don't know, but I stayed sick for about 5-7 years. And then I met a therapist. She wasn't an eating disorder expert. but she was helpful. She was supportive. I had a good relationship with her. And I said to her, but do you think that the treatments, the admissions you had were a waste of time? Was it just her who helped you get better? And she said, oh no, I pulled out all my workbooks from the inpatient unit and I started doing the things that I had done to gain weight in treatment. And it's like I had kind of muscle memory, but I wasn't ready to enact anything until then. And so I think that kind of illustrates how we just sometimes we don't know what a failed treatment is, and we don't know when someone is going to be ready. I've had patients like this one who came back and said they were recovered because my mom got cancer and I realized it was time to change. So I don't know, I'm not exactly answering your question, but I think I wanted to kind of make this point about the importance of non-specific aspects of treatment that probably help patients, but also the importance of specific aspects. In other words, aspects targeted towards weight restoration.
Yeah, no, I'm so glad you brought it up. It's partially also just underlining that we don't know who's going to get better or when, and sometimes there are many experiences in treatment that someone on the outside might look at as a failed treatment, but actually is part of the recovery process.
And I'm sorry, let me just add one thing, but along the same veins, I think there's therapeutic alliance. There's also kind of iatrogenic alliances with treatment providers. And iatrogenic interventions are ones that cause harm. Yeah. And we have to wonder what the effect of a trusted provider who suggests to a patient that maybe they have an untreatable illness, but that they can help them to have a good death. What kind of influence is that?
I'm so glad you said that. And I was thinking about it the entire time you were talking about therapeutic alliance. I'm glad you said it out loud. It's hard to look at, especially if that treatment provider might have been a well-meaning person. But I think it's really, really important. You know, we learn and we think about this, and knowing that the consequence is so great, that we consider that possibility.
I think physicians are just as susceptible to unconscious bias as the rest of the population. And that is a big problem with this concept.
Not just bias, but exhaustion. You know, the struggle to keep somebody alive, to try to get them well. I mean, we are susceptible to our own exhaustions, which can play out in our recommendations for, you know, whether or not it might be a good idea for you to choose this other treatment option of assisted dying.
Yeah. And that's a perfect segue. I know, Dr. Wegner, you've been sitting there patiently waiting, but in some ways, Dr. Gordon and Dr. Comrade have given me the perfect drum roll to a question for you, because you are a retired palliative care physician. And one thing that we've seen happen in the eating disorder space recently is a real kind of movement. And I have to say, I have worries that it's not actually backed by the research and the science. But as people have become aware of iatrogenic harm, and people with lived experience have said, I've gone to treatment and it's been harmful for me, it's been more harmful than helpful, there's been a push to say, well, perhaps symptom reductive treatments, or quote curative treatments, or active forms of treatment that focus on recovery are actually harmful for this small number of people that have severe or enduring, or whatever language they're using at that moment. And perhaps a palliative care approach would be the most helpful thing we can provide. And it comes from what might be viewed from a nihilistic stance, that some people are just not going to get better, and the best thing we can do is offer them palliative care. I'll just mention, you and I have been going back and forth on this, but in the UK in September of last year, there were leaked NHS documents talking about the development of what were termed palliative pathways for people with severe and enduring eating disorders. And I know this is an active practice in the US of patients with eating disorders being put onto quote palliative pathways. So can you speak to your thoughts on that as a as a physician who specializes in palliative care?
Well, I think there's a confusion here between the term end of life care and specialist palliative care. In the same way that a family doctor, a GP, seeing a heart failure patient is not doing cardiology. And so, end of life care is just good care towards the end of life, which, by the way, could be 10 years away. But the point is, it could be a long time away. It's quite different from a multidisciplinary, trained, expert specialist team in palliative care. And while you may have differences in eating disorder teams, certainly in the UK, palliative care and particularly palliative medicine is a specific specialty of medicine, just like neurology, gastroenterology, and all the rest. That doesn't apply to every country, but it certainly is the case in the UK. So there's a very specific understanding of what specialist palliative care means. And I have to say, in specialist palliative care, there is no recognition of a pathway in eating disorders. The only place where I could, and I think if it was referred, if an individual with an eating disorder was referred to a specialist palliative care team, I think they would have real reservations. The exception might be somebody with irreversible multi-organ failure, where they would be treating some symptoms as they would with anyone with end-stage multi-organ failure. But I think the question at the end would be saying, what happened to allow them to get to this stage? But that is not an involvement with a palliative care pathway in eating disorders. And I have to say, in palliative care, specialist palliative care, it's quite common. Well, I wouldn't say common, but we often see some people who are referred to as supposedly terminal. And it turns out that that's not the case at all. And you find actually there's something completely retrievable. There are lots of mimics of dying situations that can appear that somebody is dying, and in fact, nothing can be further from the truth. And you actually have a completely reversible situation which you treat. Now, when it comes to young people, it's always possible that there's a young person with an eating disorder and other comorbidities. But bear in mind, in children's hospices and young persons hospices and palliative care, prognoses are often 5, 10, 20 years. That's the common situation. And if they had somebody who also had an eating disorder, they would be linking up with their local specialist eating disorder team. They would not be trying to do this on their own, and they would be looking to actually encourage and support the individual, support the family. So I think there's a lot of confusion between end-of-life care and palliative care. The problem we've got is that assisted dying campaigners have loved to blur the boundaries. So they say, oh, this individual had a bad death despite the best palliative care. And when you inquire, you discover they actually had no palliative care whatsoever. And they had maybe a family doctor who visited once, or they saw a palliative care specialist once, and they never had any specialist palliative care. And it's being used, and the blurring of that boundary is being used to provide legitimacy to the whole thing of assisted. And I have to say, it's physician-assisted suicide and physician-assisted euthanasia. I emphasize the term physician, because one of the big problems we have, and you've been discussing it already, is that we're handing this decision to two isolated doctors who decide in isolation, who decide without any monitoring, who are rarely reviewed, in complete contrast to any other difficult decision that has to be made in healthcare or social care. And it's a recipe for hiding errors, bias, discrimination, and even criminality. And we need to separate these two. And I think one of the big problems, and I'm a doctor, many of us are in this situation, in this webinar, we're the last people to be dumped with this decision. And Mark has already explained that this is not a medical issue, it's not a medical decision. but it's being used by assisted dying campaigns to provide a veneer of respectability, a veneer of legitimacy. And in fact, the legitimacy is emperor's new clothes. There's no legitimacy in two doctors deciding this in isolation. You end up with doctor shopping, which has already been mentioned. This is a disaster. So there is an issue. The problem is the medical model of assisted dying, and that's a major problem we have. So I would say the issue is that in specialist palliative care, we do not recognize a pathway for people with eating disorders.
Yes, Dr. Conrad.
If I can just add a wonderful quote from Christopher Belaguer, who wrote in The Guardian to Claude's point. He said, "Is the most solemn and consequential intervention a physician can be asked to make. In this context, the decision to kill is oddly contingent on single mercurial human consciousnesses." These two, and I spoke before about futility as a kind of shibboleth, as a straw man construct to create a veneer of acceptability. I think that this idea of palliative care, palliative psychiatry, is another version of a sanitized, acceptable veneer that makes it sound like we're doing a good thing if we're going to stop mainstream treatment for a patient, because we have this whole other specialty. And by the way, it is a specialty in the United States as well, called palliative care, that we can hide beneath in order to sanitize the removal of effective and state-of-the-art treatment for any one individual.
And a
Yeah.
common argument we hear is saying, come on, you doctors make life or death decisions all the time. We're going, no, we don't. We don't stand at the foot of the bed and go, well, you're going to live, you're going to die. It's about a shared decision making, firstly with the patient, ideally with the family too, but also it's a shared decision making process within the team itself. And within that team, not only is that decision shared, it's also documented. And that's in complete contrast to the medical models that are being practiced in all other jurisdictions. And it's hard to understand how politicians can't see this. But politicians are driven by multi-million dollar and pound campaigns. I mean, there's one organization in the UK which last year its income was 2.2 million pounds. And we're not talking about the other organizations. These are hugely, I have to say, very good multimedia campaigns, and they're very good at going at politicians. And so the facts are largely dismissed, countermanded, and they seem to be quite happy to use, which I hate to use with US colleagues here, Trumpian ideas of arguments where, for example, they attack palliative care, firstly saying we kill patients with our morphine, which is odd because morphine is almost not a component in assisted dying drugs. Or they attack us for prolonging people's suffering because we won't agree with the idea of assisted dying. The fact that they're two entirely opposing arguments is not a problem. They're also quite happy to give untruths and other issues. So we're dealing with a real issue, and it's very difficult to get hold of facts.
Claude, we
Yeah.
also do not stand at the foot of a patient's bed, not just to say you're going to die, you're not going to die, but to say to one person, I'm going to provide you the means for suicide, or in fact, I'm going to start an IV and kill you. That's also something that we physicians do not do through the venerable history of 2,500 years of medical ethics.
I mean, it has happened. I mean, not just to, we have had in history, we've had euthanasia before. It was not the voluntary, I know people don't like us to bring this up, but it has happened. And, we have historical amnesia. around the last time that we had doctors deciding who lives and who dies. It was not that long ago. We are in our last few minutes, so I want to invite those who are with us to submit your questions in the audience if you have any. I mean, I still have 4 questions left that are written and a number that have just come to me as we're speaking. So I'm just going to throw one to you all. While we see if anybody else weighs in with a question. Oh gosh, which one? Yeah, I want to go to what you were speaking to, Dr. Comrade, around, suicide versus suicide prevention. One of the most, as somebody who's had an eating disorder and working with people that are struggling with this every single day, one of the most heartbreaking aspects of this is that you may have a person who is deeply suicidal, who is coming to their doctor and saying, I no longer feel my life is worth living. And rather than being given suicide prevention care in that moment, they may actually have those what I would call psychopathological beliefs affirmed by their care provider and be given a lethal prescription. So can you speak to the danger of bringing assisted suicide and euthanasia into psychiatric care in terms of how would one even make a decision as a physician or a mental health provider on who gets suicide prevention treatment and who needs to be helped in committing suicide? And I'll say specifically, I heard this week from somebody who said, well, isn't it better than a big bottle of Tylenol? Or isn't it better than them jumping off a bridge? That was literally something I heard from someone this week. So can you speak to this?
Yeah, well, the provision of suicide is really anathema to psychiatrists. As you point out, it is our professional ethos to prevent suicide, not to provide suicide, to help people find some kind of path to a better future, to help them, even make meaning of the suffering that we cannot alleviate, to help them with their coping systems. Somebody comes knocking on our door, that's what we do. We do not actually aid, abet, and provide suicide. And I think to do so is a betrayal of the fundamental meaning of what it means to be a mental health professional. And I want to be clear that these kinds of procedures, they are a form of suicide. The American Association of Suicidology for a while tried to distinguish that they're not. We shouldn't even call this suicide. However, ultimately, they decided that was not a sustainable distinction, or that, in fact, one cannot really discern one category from the other. And so they've actually backed away from that distinction, because these things create sort of 2 tiers of suicide, the good suicide and the bad suicide. And that kind of creates a halo around suicide, which is problematic, because one of the important tools in the suicide prevention kit on a public health basis is actually taboo. And taboo is not the same as stigma. We don't want stigma for suicide, but taboo meaning, it's not a cool thing. It's not a good thing to seek and get the means and to implement suicidal behavior. But in setting up these 2 different kinds of suicide, we are threatening the taboo, because there is supposedly now a subgroup of people for whom suicide is not just okay, and it's desirable. And that leads to some worries about suicide contagion. So we have a phenomenon, and we've seen this in many, many different examples, in which celebrities and very romantically reported suicides actually cause a contagious effect by elevating other suicides. In Oregon, in the United States, since Oregon allowed assisted suicide in 1996, the rate of suicide has increased in the US by 40%. However, in Oregon, the rate of suicides has increased by 75% over that same time. So that's curious. Now, of course, correlation is not causation. We can't say exactly that was produced by having a domain of acceptable suicide that we should provide rather than to prevent, but it's certainly worrisome. And studies that have been done in Europe, looking at Belgium and the Netherlands compared to surrounding European countries, have also shown similar kinds of results, suggesting that there may indeed be suicide contagion. And none of this was studied. Nothing was studied, frankly, prior to the legalization of these kinds of procedures.
Thank you, Dr. Conrad. I'll also just say that there's evidence that women in particular are more likely to take up physician-assisted suicide. And our study you cannot draw conclusions because our N was so small and there was so little reporting. But of the 19, there were 19 cases out of 60 something, because we can't confirm how many there were in the US, just that they occurred in 3 states. But of the ones that had demographic characteristics, 100% of them were female. And of course, eating disorders generally, that you can say that it affects more women than men. But I see your hand up, Dr. Wagner, so I'm going to go to you.
Just to say that assisted dying campaigns say, look, the evidence is very clear. Basically, it's widely used because it's safe. Why is it safe? Well, because it's widely used. Why is it widely used? Because it's safe. I mean, this is the sort of argument that basically bloodletting, was used and leeches were used. All right, there's a role for leeches now, but it's fascinating. Now, I don't know if anybody's aware, but there isn't a single drug regulatory authority anywhere in the world that has approved assisted dying drugs. Not one. Oregon provides the best data, but a lot of their data is missing. 3/4 of their data on complications is missing. They destroy all the source material 1 year after each annual report. Now, how many of you would be allowed to destroy your patient's records 1 year after you'd produced a report? It's just crazy. Many years ago, we know the story of thalidomide. 17 countries approved thalidomide. The US was one exception, and the person who refused it actually got a presidential medal for it. But despite that, there was a huge amount of information available, and we know the outcome. A vulnerable group of people were greatly harmed, and yet there was vastly more evidence for thalidomide than there is now for assisted dying.
Yeah, we may write another paper on this, because in the US in particular, because it's physician-assisted suicide and it's generally orally administered, which is different from other countries. Most of the research on the drug cocktails that have been constructed have not even gone through an IRB. It is research on human beings who are dying, but it's not even being regulated by IRB, which is to me just unfathomable. And you've seen long death, you've seen significant complications, but I mention that only because I think in the eating disorder world, this is often hailed as a quote good death. How would you know that? You have no way of asking that patient as they are dying, are you in pain? Are you afraid? You have no way of knowing that. And especially if the death lasts for multiple hours. And some of these drugs are being used in remarkable quantities, very, very large dosages. I think I've got one final question, because I really want to fit this in, Dr. Hansen, because I know you wanted to speak to it, and then unless we get something else, we'll end here. But Dr. Hansen, you've really spoken to something that I think is under talked about in this issue, which is that assisted suicide can have profound implications for individuals in institutional settings, so prisons, psychiatric facilities, and care homes. Can you speak about the impact on these individuals? Because when we make a new law, even if we give that it might quote help some people, it also has an impact on the most vulnerable individuals in our society. So can you speak to that?
Absolutely. And I really appreciate being able to leave this as a final word. I wish my words could be in all caps, because in my opinion, this is the most important, less considered issue that our legislators, our politicians, our elected officials, and especially our professional organizations need to hear about and think about. Right? 30 years of my clinical practice has been in state institutions, in jails and prisons, and in a forensic hospital doing court-ordered evaluations. Okay. These are people who are confined indefinitely. Insanity acquittees in our forensic hospital is most of our state hospital population now in the United States. These folks are not being released without a court order, so they're there indefinitely. Our prison population is aging. Many prisons have palliative care units now. There is a provision for medical parole or compassionate release that almost never happens. Okay. And so this is a big problem. And I think about this because I look at what happened in California when they passed their law. The health department immediately opted in. They adopted regulations that allow a patient in a state hospital to go to court in front of an administrative law judge and get an order to provide the lethal medication. What this means is that a physician, a psychiatrist working in a state hospital could get a court order requiring them to prescribe lethal medications. Now, talk about awkward moments. If you say no, you risk being found in contempt of court. That's a serious problem. A similar law was passed recently in my own state where a patient can go to an administrative law judge through the patient grievance system and challenge their treatment plan to get the treatment they want. The California regulation would require the hospital to provide the medication in the facility. Okay. Now think about what that means for everybody else in the hospital. I'm really glad we've had discussion about the importance of the doctor-patient relationship, right? I can tell you as an institution-based psychiatrist, one of the first hurdles you have to overcome is this idea that you can't be trusted, right? So your patient looks at you and they think, there must be something wrong with you if you're willing to work in a place like this. I take it for granted. We have to overcome that hurdle even without this practice, okay? In a psychiatric hospital, some of our psychotic patients refuse medication specifically because they have a delusion that the medication is poison. What are they going to think when they find out the doctors actually do prescribe poison? Okay, what could possibly go wrong? Okay, we've already talked about suicide contagion. That's a well-documented phenomenon. That's the bread and butter of what we do in our state institutions. We identify people at risk. If a death by suicide happens in the facility, we immediately intervene to assess everybody else on the tier to make sure they're doing okay, to make sure it doesn't spread. So introducing this practice into a state institution, it's like introducing a lethal virus into a crowded room. What could possibly go wrong? Okay. Now let's switch over to prisons. We talked a little bit about compassionate release, palliative care. In Canada, they are providing lethal medication to prisoners. Okay. Now imagine how that's going to work. So patients in a palliative care tier, they ask for lethal medication, and, assuming you can find someone willing to do it, which no physician I know of in a state institution wants to be involved. They say, okay, you can do it, but on the condition that you do it in the community. So we will release you on parole into the community if you want to kill yourself. Okay. Well, remember, this is a voluntary process. You don't have to do it. What a great way to get out of prison, right? If you want to get out of prison, just ask for lethal medication. You've just built in a coercive incentive to request death, right? And what happens if the person decides not to take the medication? Does that mean you just violated your parole and you have to go back? Okay. Again, it's crazy. Okay. And then finally, this creates a real huge conundrum for physicians specifically in the United States. So our federal laws have never recognized the proponents' redefinition of this as something other than suicide. Under federal law, this is suicide. Okay. We have a federal law called the Civil Rights of Institutionalized Persons Act. It was created many years ago in order to protect these vulnerable patients. And it requires facilities to provide suicide prevention services to prevent suicide. Okay. But at the same time, we have another case, a U.S. Supreme Court case, Estelle v. Gamble. And that case says you can't deny a legitimate medical intervention to someone just because they're institutionalized, right? So here's the doctor in the middle. You've got the U.S. Supreme Court case saying you've got to provide it, and then you have the federal law saying you must not provide it. So institution-based doctors are caught between this legal rock and a hard place. And you talk about a slippery slope, but when you come to state institutions, this isn't a slippery slope. This is a cliff. Okay. There have been requests. So this is the burning area of litigation that we're going to have to think about, that our politicians and legislators need to think about when they're looking at these laws. Okay. You don't want, if you're in a professional organization and this comes up, remember that if you support these laws, you are throwing your physician colleagues under the bus if they work in a state facility. Thank you.
Thank you, Dr. Hansen. I'm glad we ended on that. And I would just say, if I had to sum up this entire thing, the devil is in the details. It really is. The devil's in the details. So I want to thank you all for being here today. I also want to thank Doctors Say No International for co-hosting this webinar with us, or panel discussion with us. Do go and visit their website, especially if you're a physician. You can sign their statement, which is impressive. They've got a really wonderful counter on their website, 544 signatories from all over the world. We also have a joint statement specific to eating disorders on the eatbreathethrive.org website, and that is a statement calling for the prevention of assisted suicide in people with eating disorders. So I invite you to sign that. I want to thank our excellent panelists. We covered a huge breadth in a short period of time. So thank you for taking time on your weekends to be with us. And I look forward to seeing you all again soon.
Thank you very much.
You.
Thank you.